Very good evening, and thanks to everyone for joining us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chabra and Mr. Amit Saxena from Medical Services, and Mr. Raj Kumar, Area Sales Manager, South Delhi from Naari Division of Jagsonpal Pharmaceuticals Ltd, welcome you all to the new episode of the series Pearls of Wisdom Key Opinion Leaders, organized by the Society of Meaningful Life Management. The academic partner for today's program is Naari Division of Jagsonpal Pharmaceuticals Ltd, makers of Fibristone 25 mg tablets of mifepristone, the safe alternative to surgical management of uterine fibroids. Also, Yuliprist 5 mg tablets of ulipristal acetate for the long-term management of uterine fibroids, and EndoReg 2 mg tablets of Dinogest for the management of suspected and confirmed cases of endometriosis. We extend a warm and hearty welcome to the esteemed experts and attendees. Dear attendees, we request you to post your thoughts or opinions by text in the Q&A box. Please note this webinar is streaming live on the Facebook and the link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel Jagsonpal Medical Insights. Now, we welcome and request Dr. Maninder Ahuja, ma'am, the progressive, thought-provoking leader, creator of processes of going digital, online voting, e-newsletters, online journals, and the founder president of SMLM, past president Indian Menopause Society, and Faridabad Obsgyn Society to kindly initiate the proceedings. Over to you, ma'am.
Thank you, Jagsonpal Pharma, Mr. Ankit Dogra and Deepika Chabra for being our technical partners. And at the outset only, I must thank Jagsonpal because they have been my support from the very beginning. When I first did the first research paper on the age of menopause and determinants of age of menopause. And that paper is still quoted internationally because age of menopause is very, very important determinant of so many problems, infertility, cardiovascular disease, osteoporosis, everything. So thank you, Deepika, for helping me with that. And about the Society of Meaningful Life Management, yes, we did register it in 2019, July, with the aim of let's go digital. But then Corona came in December and March 20, we were all locked down and COVID taught us, let's go digital. So that is what one of the dreams of me was, because we were not being that effective. We were not reaching to the last mile, whether it was to the doctors or to the public even. So I think that one angle of COVID has been a blessing, but of course we have been through horrifying times and we don't want it back. But I'm still scared, I must admit to all of you, that COVID is perhaps going to have long-term sequences and we must keep our eyes and brains open to it. And whenever we find such cases, we should go on reporting it. Now, other activities of SMLM has been to bring all the medical professional organizations on one platform, because we see now the distress against the doctors in the media, in the public, and even the government of India machinery also. So why that distress is there? Why? Is it because of the financial differences which have arisen because the public was not ready for such a huge explosion of technology which has taken place in the last few years? And that technology, of course, brings in the rise in the cost to the treatment also, because no way you can have that cost, neither the government of India nor the private practitioner. So perhaps the public was not prepared for that. So to help that, how we can? Individually, all the organizations are strong who are dealing with the health of women of India, or even for that matter, men of India in any way, all the medical practitioners. But we have different voices. So my aim is, if we can have one voice together, we will be more effective. That is what happened during COVID-19, when the government of India was not willing for vaccination against in the pregnant women, all the organizations, they came together. We from the platform of collaborative group also gave that those statements. And when the media raised that question, and once when I heard that media and I was called for the news channel, they said 14 organizations are giving that statement that the COVID-19 vaccination is safe. Am I being heard? Because light has gone. Okay. So this is not there. So that is one of the things. Then Pearls of Wisdom series is by our key opinion leaders who have done so lots of work in their fields, but somehow or the other their work is not being shown. So keeping those in mind, this is our fourth of the series in that direction. Dr. Hema, Dr. Narendra, all of them, they have come. President of the IMA also has those series. Today is a very, very important topic. Yes, these are the series by Dr. Hema Divakar, Dr. Pankaj Desai, Dr. Jaideep Malhotra. So they have talked on different subjects. And now we have fourth in the series by none other than Sunita Tandulwadkar. Sunita, do you have those mementos with you?
I have not received, dear.
Okay.
I was told probably it may be on the way. I was told to keep it, but
Okay.
I checked even today late afternoon and it was not.
It's fine. It's fine. No problem. That will be sent to you because we are honoring all our esteemed speakers who are the masters of their fields. But masters sometimes have also been shown to the media because we are not reaching out to the last mile or the last persons. And so many of our even medical colleagues don't know what we in India is doing. So our purpose is to show their work also. So today we are going to talk on a very important topic and very common thing, myomas. So myomectomy, when, how and where. But before I talk about the topic, I have to share with you a few things about Dr. Sunita Tandulwadkar. She is the head of Department of course, and Chief of IVS and Endoscopic Center, Ruby Hall Clinic. And perhaps the Ruby Hall Clinic is known with the synonymous with the Dr. Sunita Tandulwadkar only. So that is how she is known in Pune also and all over the world. And when I had met her first time, I think about 12 years back in one of the FOGSI conferences, I could see her as a white orchid. She was in white dress and she was like a blooming flower only. And she has bloomed a lot in all these years, academically also and in her personality also. And she is advisor and consultant to D.Y. Patil IVF and Endoscopic Center, Pune. And she's also founder and medical director of Solo Clinic IVF, a center of excellence in infertility in Pune, and founder and medical director of Solo Stem Cells. That is something novel which she is doing, research and application center in Pune. And she has already done a few cases in that, successful cases which have been published also. So as far as the first stem cell baby and world's first at the age of 45 years to women for 45 years was given with the help of stem cells only. So when we talk about menopause, I think our hope will be Sunita Tandulwadkar also, so in that area also. So as far as we look at her academic affiliations, I think she has worked into lots of organizations and very successfully on top of that. So she was the president of POGS, just now given her handed over charge 2021 to 2022. And then chairperson and founder honorary secretary of ISAR, senior vice president in ISAR, then president of IAGE 2019 and 2020, then vice president of the West Zone FOGSI 2015 to 2017. I think, Sunita, I was vice president earlier, 1 year earlier to you. Anyway, elected board member of ISG and reviewer and advisor of Journal of Human Reproduction Sciences, and authored many books and publications and delivered, of course, many keynotes and orations also. And she's awards, if you go, there's a long list of awards, but I'll be just reading a few only. Icon of the Year 2022 Endoscopic, Economic Times Bharat Gaurav Puraskar, then Best Medical Practice 2016 European Medical Association Best Citizen of the India Award. That is the best work, Sunita, I think you're doing. When you get an award as a citizen, that means it's not only that you are acting academically, you are looking after our corporate social responsibilities also. And I think in this scenario, this is very, very important that we look after those duties also. Then she has got Rashtriya Gaurav Award and Sarvashri Award and letter of appreciation from the President of India 2012. So Sunita, I think it's an honor to invite you on a very common topic of myomas, when, where, and how the myomectomy is done. And the thing is that this thing is seen in the women from very beginning to end. And women with fibroid have to traverse all the milestones from adolescent to pregnancy to menopause. Sometimes they have to live with it. Sometimes the fibroids say, why I'm a small one? Why are you trying to remove me? But the technology has made it to diagnose us, even the seedling fibroids are there. But when to remove it? That is very, very important issue which we should be tackling and giving a very clear-cut message to the doctors when they should be removing it. Along with this, I welcome Dr. Dinesh Kansal also. Can you please show her CV, because then they can take it over from without any break. So Dr. Dinesh Kansal is the president of Delhi Gynec Endoscopy Society and convener examiner for ICOG fellowship program, director and head at the B.L. Kapur Hospital. But the main thing is that she is a robotic surgeon trained at Harvard University, Boston, graduate and postgraduate from the Grant Medical College, Bombay. So we have another alumni from the Bombay, and organized and operated in many national and international workshops, including AAGL, FOGSI, and CEPOGS. She has got the very prestigious Satyapal Award, Times of India Excellence Award, Abdul Kalam Award, and Best Video on Histoscopy Awards. Successfully running laparoscopic surgery fellowship program at BLK, published various articles in books and journals. So it's an honor to welcome you here, Dr. Dinesh Kansal, on the platform of Society of Meaningful Life Management. And we always endeavor to give a meaningful meaning to our webinars and our whatever efforts we are doing in reaching out to the public and to the media and to the medical fraternity also. Her award is there. I think she received in person. Yes, thank you, Dr. Dinesh Kansal. You have got it. Do we have Dr. Subash here? Subash is here? Okay.
Yes, ma'am, he has joined.
Okay, yes, joined. So he is the gynae endoscopist from Germany. He has done, and P.V.S. Hospital and Baby Memorial Hospital, Calicut, Kerala is where he is working, and he is the DNB Guide and Examiner, National Board of Examination, Delhi. I'm inviting one and at the very senior and then and young upcoming, so that they can meet together in their thought processes also. So he was the Chairperson Medical Legal Committee, KFPORG in 2021 to 24, and Chairperson FOGSI Endoscopy Committee 2021 to 24, and then Secretary Calicut Society 2020 onwards, and Managing Committee member of IAG 2019 to 20, and FOGSI Mentor Mentee Award 2019. So welcome, Dr. Subash Mallya. And I hope once Dr. Sunita has given this talk, you will be taking it over from her and giving the meaningful messages to all our audience. And again request the audience to please post their questions in the chat box, so that question answer box, put it there so that we can take it at the end of the talk. Now, Sunita, the stage is all yours, queen, our queen of hearts and our queen of academics, Dr. Sunita Tandulwadkar. Please.
Apologies, ma'am. I was in an ectopic. I'm really sorry. I was in an ectopic. I just finished the case. I finished the case. I'm now free, ma'am. I'm sorry for the delay, ma'am.
Okay, but your topic did not give you ectopics. That is very good.
So thank you everybody. Maninder, I love you. I know Maninder for years and ages and decades, and she looks the same for years together. Also, this is what the FOGSI makes us. Every FOGSI managing committee meetings, there are so much activity, so much enthusiasm and passion. Many may not know she was so perseverant that the Menopause Society name should be changed to midlife. Those who are youngster, though they know that so and so is a chairperson of a midlife committee, but they should know it is Dr. Maninder Ahuja. I still remember every meeting till it got passed. She could convince each and every sitting president and the secretary general and the entire managing committee. She kept on perceiving, and I still remember, because every managing committee meeting even I attend, and the way she perceived, and she ensured that no one calls it as a menopause society or a menopause committee. She loves to call it as a midlife committee of FOGSI. So Maninder, I love your passion. Your another passion is your dance. You perform. That's your spirituality. That's your glory. And age doesn't matter when it comes to Dr. Maninder Ahuja. Her passion is absolutely amazing. And now she comes out with another society. When you asked me, I was thinking, what is this MLM? So I realized that if person has a passion, she can excel in any form. And I'm thankful to Jagsonpal, who is giving her right support. Mr. Ankit and Dr. Deepika, you are working with her. You are working for the society and you're working for the women's health. So thank you so much. I think I will give a 24 minutes ka my audio video recording I did, so that we finish. Otherwise we get carried on. And Maninder said this thing, most important thing is our discussions and question answers. So the flow will go like I give a talk in 25 minutes, then I take a question, then Dinesh and Subash will have their videos and their talk. Now let's talk about my topic given to me, laparoscopic myomectomy, how and when. I usually do the recording not in a Zoom platform, but on a Prezi platform, so that people can see and even I can get the feel of video recording. This is greetings from Dr. Sunita Tandulwadkar from Pune, and I thank you very much. Friends, advances in science is always for the betterment of human being. Until recently, the fibroid management was, if in doubt, cut it out. Development in a surgical technique and ease of doing it has led to many unnecessary myomectomies. Incidence of myoma in a reproductive age group, though, is very. So we all know this is a FOGS classification which we use, and we decide the location, submucous, intramural, and subserous in a broader way. And let's see how we would. Main question is whether we should remove these myomas or we should not be removing these myomas. Does it depend upon the size? Does it depend upon the number? Does it depend upon the site? Or is it that it depends upon the relationship of this myoma with the cavity? So with this talk, I will be just giving you more on the highlights of these. All submucous myoma and all cavity distorting myoma has to be removed. Again and again, publication has proven this, that submucous myoma we should be taking out. There are three submucous types we call. Type O, when everything is projecting in the cavity. Type 1, when more than 50%, and type 2, when less than 50% is projecting. So when it is a type O that is completely in the cavity, you can just resect the base of a myoma and allow the myoma to disintegrate on its own, or you keep on resecting what we are doing age-old. So you can have a resectoscope going in, or I can just have the scissor coming in and just cutting the base. What is important is you should be giving the patient antispasmodic if you are keeping the myoma in the cavity. Will not have any other side effect. Just give us antispasmodic so that she will not have a uterine contraction, because when this myoma is getting expelled, she may have an expansion. Sometimes you may have a challenging situation. Have I overcome one video? No. You have a challenging situation like this. It is type 1 myoma where more than 50% it is protruding. So first thing you should do is ensure that you tell the patient, I may do in one go or in 2 sittings as well. Sometimes the pressure difference is more than 1 liter. Even if you are using bipolar, it is a normal saline which is more than 1.5 liter. It is important that you should stop to avoid the fluid overload. Secondly, these are the rigid telescope and resectoscope. So they may not go in a depth, especially if it is a large type 1 or type 2 submucous myoma. I'm trying to hook it. It is not getting hooked. So it means it is still the cavity. It is adherent. You can appreciate the wall outside and this myoma. Don't damage the basal endometrium. So try to take smaller chips, 2 millimeter, 3 millimeter chip. Surrounding myometrium can be very well seen. You can increase and decrease the pressure. So that is called hydromassage, which can loosen up from its capsule. And you can then keep on taking out the small pieces. Now, sometimes, friends, it may be that you have just resected and then take a Collins knife and just push it inside. So instead of a finger, how in open myomectomy we used to do in our residential ages, this is how with the Collins knife, I can just enucleate, hook it out and keep it out. So you don't cause any damage to the basal endometrium. Sometimes the myoma may be type 2, but if you see there is a serosal surface bulge, then instead of going hysteroscopically, I may go laparoscopically and take out that myoma, which is just the job of 10 to 15 minutes. So whether to do hysteroscopy or laparoscopy for type 2 is your choice. Be thankful to each new challenge because it will build your strength and character. I'm demonstrating this 10 centimeter large myoma. Anyone is justified to do this laparoscopically? But this was a young unmarried girl. So we used to do, this is very old video of 2003, 2004, where we used to call it as a mini hysteroscope for an office hysteroscopy. This is a 2 millimeter telescope passed in to evaluate where is the base. My preoperative diagnosis was type O. I wish to go hysteroscopically and I can see from a right lateral wall, it is the base of a myoma and I can definitely think of maybe in one sitting, maybe very difficult, I may do in 2 or 3 sitting. This is what I told the patient. Now here what I'm doing is, I'm not closing the loop. I'm going beyond the myoma and I'm coming to the whole length of a myoma. You will see very large open vessel channels. Don't bother. Just keep on resecting. This is the vessel channel, which is so broadly open. This is wide, 2 to 3 millimeter. So it can absorb a lot of fluid. So your speed of a surgery matter. Another important tip is don't waste your time in taking out these pieces. With your hydropressure, they will go out from the field, surgical field, and you will keep on doing. If you want to take out this, you will see that when you enter back, your cavity is full of all the blood and you will waste another 2 liters to wash that blood. So you are seeing I'm not closing the loop and I'm just resecting one after the other, large, long tubular pieces. Now, very important to hold yourself and see where you have. Now you can see, I can see more than 50% cavity, long pieces. I just take a right turn because I saw it is coming from the right lateral wall and I can proceed. So fortunately, this case I could finish in one sitting. But I don't say that it will be possible. Very old photograph mine because this is an old case. Sometimes you may land up in multiple myomas. So very tricky, this submucous myoma. I don't advise you to give a GnRH to this patient because if there are small myomas of 5 millimeter to 1 centimeter, they will get dissolved, they will disappear. And maybe 6 months after the surgery, they will come up. And then patient will come back with other fibroid saying you have not done the job perfectly. So I will never suggest, maybe you do 2 or 3 sittings. It's your choice. If I go more deep inside, can you see that? These are the smaller myomas which will disappear with your, this is another myoma to the anterior abdominal uterine wall. They will disappear. So you may not resect both antero-posterior wall together. This is another beautiful case I had where 19 to 20 submucous myoma. You can watch on a YouTube. I have posted this. I went in and in 30 minutes, I took out all the myoma without coming out a single time. So sometimes there are challenges, but you should know how to enjoy with them. Now, when we know submucous, I need to remove. What about subserous? Subserous fibroid do not affect the fertility or they do not cause abortion, and please don't need to remove them. Sometimes after the surgery, you may cause iatrogenic adhesions, distortion of a tubo-ovarian relationship, but where I will remove, I will show you as the time passes. Now, intramural myoma, which are impinging the cavity, they need to be removed with care. So this is what the mapping of myoma I do. I don't do the MRI for my patient because I have a fantastic sonologist with whom I'm working for last more than 2.5 decades. I sat with him in 95, 96, and I asked him, can you do this mapping for me? And we both sat and did nearly 1 year working. And we then realized that whatever he says, precise location, I get inside. So very important, you have to have such a team member. And then we do intracapsular myomectomy. Now, what is intracapsular? Can you see this? The cavity, that dark blue color was a cavity. If you see that, I'm so sorry, it is not stopping here. This is a cavity. Now, these are medium-sized myomas. But if I open them, cavity at a time, I will give an iatrogenic infertility because of a intrauterine adhesion. So I will explain the patient. If I open the cavity with the first myoma, I will go for a second, and if I have opened second time also, I'm not going to take out the third myoma in the same go. So this helps you to preoperatively counsel the patient. Now, these were shown as a medium-sized deep intramural compressing the cavity. So what I suggest intracapsular, it means you do the fiber by fiber dissection and take out this capsule also. So your endometrial cavity and the capsule is behind and you are suturing. So first myoma is out. The vasopressin action is just for a 15 to 20 minutes. So I usually like to suture immediately after the myomectomy. Vlog has made our life very simple. It allows a good obliteration of a dead space, but you take this baseball suture so that there is no exposure. Now, second myoma, he told me on the left side, on the posterior fundal, little mid posterior. So I'm going in, you appreciate the depth of our penetration and the intramural myoma, which I have cut. And this second myoma is out and the cavity is not open. So you can go for a third myoma as well, but only after suturing and only. Another thing is you can put 200 cc of a fluid and ask your vaginal person, the resident who is holding the helices or the manipulator, to see whether there is a fluid leakage coming in, so that you will know 100% that it is not opened. Now, once you take this, now it was very difficult to see where the third myoma is. In laparoscopy, there is no tactile sensation. You have to just judge it. And this is how my third myoma is coming out, and we could do all the 3 cases. Now, in this case, this myoma was a culprit, but I don't wanted to go with the hysteroscope, though it was a complete submucosal, because even if this start bulging, this will become a submucosal and then other will come. So I better take out all the 3. So this is what the importance of a mapping. Even if it was a submucosal, I knew that in the moment I come out with the least resistance path, this myoma in no longer will be a type 2, then type 1, and it will become a type O submucous myoma within a year. So I better go laparoscopically and take out all these myomas one after the other. So this preoperative mapping helps you. For example, here the fundus is completely compressed on a right lateral wall. With this, I know I will take out this myoma intracapsular way and I will not distort. Sometimes this is a subserous fibroid. I don't need to do anything for this, but it had another myoma with it. So if you see, there was no bulge there is another myoma here, which was cavity distorting, which was compressing the cavity. So since I'm going, I might as well take out this myoma. It will take me another 2-3 minutes to work on this. I'm trying to show you different energy sources from ligasual to harmonic to bipolar to enzyme, just to demonstrate the various energy sources. Because if you are doing for last 3 decades, probably like a fool, you'll end up in buying all the technologies and all the machineries, or sometimes in a corporate hospital, every consultant has their choice. And that's why in an institute, you have all those machineries with you. Now, when you take a baseball with V-lock, don't do this, what I have done, 2 to 3 loops together and I'm pulling. Now, what is important is this patient, if you see, there was no bulge anteriorly or posteriorly, but I was knowing the myoma is compressing from the anterior wall. It is deep down 3 centimeters. If I would not have done, I would have gone from posterior, would have traversed through the cavity. Anytime you do the cautery, always on the myoma and never on the bed down. And then 2-layer or 3-layer closure, choice is yours. What is important is obliteration of a dead space. Usually when it is a medium size like this, I do 2-layer, but if it is 20 centimeter or large, I take 4-layer suturing also. What is important is good obliteration of a dead space, no cauterization on the bed, so that there is no necrosis or a secondary infection. Now, this patient had a complete anterior abdominal, anterior uterine wall, complete subserosal fibroid with little bit unexplained infertility. There was no other cause, associated endometriosis, but I need to know what is the infertility. So I will never tell this subserous myoma is a cause of infertility to my patients, but if they conceive after that, then you may say probably it might be. So I needed to do the laparoscopy to know what is the tubo-ovarian relationship, is it compressing? But since I'm going in, might as well I take out this myoma because it was a large myoma. And as my sonologist has shown, it was a longitudinal long oblong. It is just the same way. So my incision was not big. It was a small incision of 7 to 8 centimeter, and I'm just closing. Now, this patient, if young, she can try again naturally. If the semen is normal, her ovarian reserve is normal, and she don't have to. What is important is your end result should be clean pelvis. See that tubo-ovarian relationship are not distorted. So every endoscopic surgeon should give a justice to the patient from an infertility point of view also. Now, this is a compressing to the cavity. Always have a habit of checking the pouch of Douglas and associated endometriosis. Now, how to decide whether oblong incision, vertical incision, horizontal incision? Usually anterior wall I take vertical and posterior wall I take horizontal. But in this case, though it was an anterior wall, I'm taking because they told me it's a very highly vascular. So one, I'm using an NSIL, and then I will cut horizontally so that I will take out few vessels from it. Now, if there is any bleeder, don't cauterize it unless it is an arterial pulsatile. You can see this is a capsule of a myoma. I did not open the cavity. It was from the fundus to the isthmus. I would have caused damage than the help. Closure done in multiple layers like this. So this is a first layer where I'm obliterating. There is a little bleeder going on. I'm not going to cauterize it, but I will move on fast with the suturing. How after taking out the baby, you just don't cauterize the wall. You start suturing, same way we should be doing. Similar cases, myomas comes in various sizes, shapes, and you keep on doing the same. Now here, the infertility, one cornu, I will not say this patient that the fibroid removal, because it's compressing cornu, I'll revert the fertility, because she had a other-sided tube, ovary, everything normal. Still, she did not conceive from that side. So you don't overpromise the patient before doing the surgery. Always allow your surgery and your results speak louder than you yourself committing to the patient. Because once I'm going in, probably I want to evaluate associated pelvic endometriosis, and that's why for unexplained. So here I have taken the incision so low down, not at all touching to the cornu. You can see this is one cornu, this is another cornu, and my incision is low down. So you may face little difficulty in suturing, but the end result is so good that again, give a chance for a patient for a natural conception if permitted. So prepare yourself well before doing your, if you wish to excel your intraoperative performance, you should be perfect in your preoperative diagnosis. Always believe in chasing excellence every day. So friends, you will land up sometimes in a difficult situation. Look at this. This patient obviously was for ART. She had a laparotomy for endometriosis outside, and she had a 3 intramural cavity distorting fibroids. Now, I can't even see the uterus. Forget about the fibroid. I don't allow the assistant to come in much earlier because they can pull more. So I'm using only my hand, and the best energy source is no energy source at all. So what I'm doing is I'm just trying to make the anatomy normal. See the uterus, because even if I see the tip of the myoma, I cannot just land up in removal of that myoma, because the closure of the bed will be very, very difficult. So first is do complete adhesiolysis. So you can see I'm taking out. Here I can visualize that the myoma is coming out, but I'm not jumping for the removal of myoma. I'm taking first the adhesions out. Then there is a hydrosulfing associated. I'm opening the lateral pelvic wall, not for anything or uterine obliteration, but to see the ureter. Left lateral wall from this side was completely obliterated. So I'm entering in just to see where the ureters are lying, and it is just the 2-minute job for you to see the ureters, and the ureters was completely to the left lateral wall. So I'm confident that I can go medially and remove that hydrosulfings completely. Once I remove that hydrosulfings, you can see now one myoma here. I was able to see the first myoma. I'm taking it out. And then I take out the second myoma, and there was no sign of a third myoma, but my sonologist has said it is from the right lateral wall, and it is completely compressing the cavity. Assistant keep on telling, ma'am, it's too much. We did beautiful surgery, such a beautiful adhesiolysis, we stop it. I will not stop, because unless I remove this myoma, I cannot give her a pregnancy. So friends, what is important is preoperative in your preparation. Now look at these myomas. They were 20 centimeter large anterior wall compressing myoma, but the patient was interested in removing this myoma. I told her, I will remove number 1, number 2, maybe number 3, but this doesn't have a bulge, so I don't know. She was very firm that she wanted and she requested, because she became intelligent to understand that in another 2 years, it may go in this direction and it may start causing compression to the cavity. So what I'm doing here, I'm just showing you the video. This was a 1 myoma, 2 myoma. I have taken out the first myoma, and as usual, I closed. And then I will go for this second myoma. So this is the second myoma I have taken out. This is a vertical incision. You can use harmonic, you can use a monopolar, and take out that second myoma as well. And then you could make the uterus antiverted. Because of this myoma, it was not possible. This is a bulge. I was told, I removed it. And then with the tactile feel that it was just 2 centimeters below and left lateral, I felt there. I took a cut, and to my luck, I got that myoma also out. Patient may not be much happy only taking this big. She will say you did an incomplete job because you did not take out that 1-2 centimeters behind. Now this is another big myoma. It is occupying nearly complete anterior wall. Now if I take an incision here, I need to enucleate this nearly 20-30 centimeters long and 15 centimeters down. It will consume too much of time, and then I have to suture also that. So I have decided that I'll take an incision U shape from that side to this side, and I may take out the uterine excessive flap also, which has grown over the period. So this is all I always say with the monopolar, I make this rangoli, because once you infiltrate the vasopressin, then this may get distorted your line. So I always decide before vasopressin where should be and how should be my incision. I was teaching to the people that if I take a vertical like this, I have to keep on extracting both the side. I took a U-shaped incision, and then I'm started extracting and removing this myoma. You can see it is so bloodless if you remain in a good plane. And I sutured on the left side, and this is on the right side I'm coming with. So friends, it is important that you keep your patience for a morcellation. Just now, I took out 30 centimeter myoma. We started at 4 o'clock, and I left half the morcellation to my team members. So very important, does the presence of non-cavity distorting myoma is deleterious? So we understood submucous myoma, yes. Intramural cavity distorting, yes. But if intramural and not distorting the cavity, do I justify? And this is a beautiful publication of a Sankara where she has taken 19 observation studies with 6,000 cycles, and she said yes, it definitely affects. So 4 to 5 centimeter myoma you can justify if there is no other cause of your implantation failure. So friends, don't limit your challenges, challenge your limit. Each day you should strive for a constant, never-ending improvement. We don't grow when things are easy. We grow when we felt the difficulties. Surgery at any age group is uncomfortable. As a surgeon, our job is to make it comfortable. Wisely find out which woman needed to be treated and which you don't. Remember, for no reason, giving a false promise of 7 centimeter subserous myoma, I remove the myoma, you will conceive. And if she doesn't conceive, she will lose the trust not only on you, but on the doctor community. And that is why we represent our community, and very important that we don't fail our own colleagues. In infertility, individualization of each case is important to ensure the excellent result. In science, the important thing is to modify and change one's idea as science advances. Thank you so much, dear friends. I little bit extended my timing, but thank you, dear, for giving me an opportunity to be with you all. And I hope I made it little more clear which myomas to be taken out. I think I always emphasize on not to operate unless you are very sure that the myoma is a culprit. Treat your patient like your sister you will do.
Dr. Sunita, it was such a mesmerizing presentation, and each word was a golden word, I can say. And you know, the audience forgot to ask any questions. They were just thinking it will go on and on. And I think you covered everything right from hysteroscopic, when to do laparoscopic, when to do hysteroscopic, and when not to use energy, and going in the proper plane. And I agree with you, like you used sharp dissection in most of the places to keep at the right plane, which is so very important to have a bloodless surgery. And nowadays, even 3, 4, 5 large myomas, we rarely give blood if the patient's originally hemoglobin is good. I'm so thankful, and I'm so happy to hear your lecture today. It's simply too good. And as you said, use energy on the myoma rather than towards myometrium, if at all. And later on, we do not use once enucleation has been complete. Actually, there is one question. If they are opposing myomas, like you had that case with so many fibroids, and you do everything in one go, do you put something in the cavity? Do you do a follow-up hysteroscopic? What else?
Yeah, follow-up hysteroscopy, yes, Dinesh. Suppose if this is patient is for a natural conception after I take out the myoma, for 6 months, I don't do anything. After 3 months, I ask them to start planning their pregnancy. I just put them on folic acid and give them 3 months break. After 3 months, I ask them to try naturally. In 6 months, if they don't conceive, then I will think about anything. I don't need to do hysteroscopy all the time. I can call them on 12th day of a menses. If she has a regular cycle, I can do their 3D sonography of the endometrial cavity. And if I find cavity is beautiful, I may not do any invasive things for her. So it depends upon the patient presentation as well.
I'm so happy you have got an excellent ultrasound person. We do not have. We have to rely more on
I know. Entire country is J about this. Yeah, Krishna Kumar the other day had referred the patient all the way to Pune to get his sonologist with you. But Dinesh, when it comes to endometrial cavity and all, we do routinely for our ART. So I don't need to send it to him. But as you say, sometimes if I find doubtful, I can always take a cross opinion for it with him than making patient. But sometimes doing an office hysteroscopy, which I do routinely, no sedation, nothing, just going in with the 2 millimeter telescope with the Caesar in. If I find any flimsy adhesion, I can just cut it also. So it become an extension of a transvaginal sonography doing an office hysteroscopy.
So for diagnosing intrauterine adhesions, if the patient says no, first tell me whether I have adhesions. Do you go for sonosalpingography?
I don't do
sonosalpingography. MRI? Nothing?
No.
So
hysteroscopy kiya, office hysteroscopy kiya, kaam khatam, therapeutic also you work. I don't think I do sonosalpingography, or I know it is a very important tool. Yahan se fluid lao, ek assistant lao, wo aadha catheter bahar, whether they have used a sterile precaution, whether you introduce infection. I'm very fussy about everything. So I better go with the more standardized way. And MRI my patient, maybe if I have suspected the malignancy in postmenopausal, these are the patient of mine. My referral to MRI is 1% in my practice.
Right. I think. And tell me if the patient has both the things, like, you removed 6, 7, 8, 9, 10 fibroids, and you find one area which is adenomyotic also.
Yes, I did not show you, but we do have it. So, but I get my sonologist telling me to on Thursday, I'm giving with Ramni very interesting adenomyosis, where I made my own classification of adenomyoma with the help of my sonologist who does the mapping, depending upon the size and the location and the relationship with the cavity. I did with my classification. I'll send you that. But my sonologist will tell me that these are all capsulated and the right lateral wall is adenomyoma. So you go well prepared inside with the patient. Now, if that adenomyoma is not at all touching the cavity, if it is outside, more of a subserosal, there is a 1 centimeter or 7-8 millimeter away from the cavity. And if it is less than 4 centimeter, I may not operate on adenomyoma. I'll remove the myomas, but I'll tell the patient preoperatively only. So she will not say you miss. And post-operatively after 6 weeks, because 6 weeks is needed for the healing of these myoma wounds. But 6 weeks after that, I'll give the patient GnRH. And I will make at least 30% reduction in the volume of that adenomyoma if needed. Otherwise, nothing. I will explain the patient. Associated endometriosis is present. Then depending upon what fertility treatment I'm doing, whether IVF or natural conception, I'll just allow them. So it all depends upon, I will not touch any adenomyoma which are less than 4 centimeter and miles away from the cavity. We will cause more damage than the help.
Right. And like we had a wonderful visual treat for endoscopy. Tell me, when would you open the case?
You know what? Touch wood. I never had opportunity to open the patient, but my all patient I take only when they give me a consent of a laparotomy. Just today, I operated a very first time in my life here, uterus cup fundus with the tube and ovary above and complete lower half 30 centimeter from the left lateral wall to the right lateral wall. I was worried. It was in the mid. It was like uterus completely shifted on a right side. From the left lateral wall, it was arising. I could feel it in the fornix, impossible to the cervix. And I was worried कि ये uterus का fundus and uterus ऊपर रह जाएगा, मैं बीच में का myoma निकालूंगी and नीचे cervix hanging रह जाएगा, and I will cause complication than the hell. And that is the on the table when everything uterus and on the tongue with the oblong myoma. After 50% myoma out, I was saying my assistant, कि just now you see the cervix from vagina, I'm pushing the thing. If you can't see the cervix, again, I'm going to open because I don't want to transect her uterus with the fibroids out in the middle, cervix in the lower part, and the fundus just today. But then he said, ma'am, I can see the cervix. I said, pull and show me where the lateral wall is going. And he could pass even the dilator under the vision and just 4-5 centimeter, and we realized that we are, as sonologist said, completely on a left lateral wall only. So we were not even crossing the cavity, and then we decided, okay, we may not open. So don't be overconfident. Second thing is, because it is me, I need to do laparoscopically. That should not be your mentality. No harm to the patient. I will send you the picture where it was so impossible to decide whether ये बीच में का fibroid, नीचे का cervix and ऊपर का fundus, I'm in a trouble. I don't know. And the patient is a young girl, unmarried from Australia. She will not be with me for a follow-up also. Forget about her pregnancy and later thing. So I needed to do the justice.
I think most of the things or what surgery exactly you will be doing are decided pre-operative, but few things remain intraoperative too.
Yes, yes, Dinesh. Yes.
And ma'am, like what are the dreaded complications you've come across during your surgery, right from beginning of your career? Now you're very expert. So right from the beginning.
As such, no dreaded complication, but bleeding. Just today, my patient received 3 blood transfusions because the size of everything was so big. And her hemoglobin was just 11. She came from Australia. There was no point in waiting. We met on Zoom meeting, and last week she did everything. There the report was 13 gram hemoglobin. When I checked, it was 11. So I said, on table, I'll decide. So intraoperative, because it was such a massive from the right lateral wall, massive surface area, whatever you said and done, your vasopressin cannot act. There was no space to go to the lateral pelvic wall. And I needed to give her a 3 blood transfusion altogether. So intraoperative bleeding is the only one. Of my adenomyoma patient, we had a rupture uterus. Okay. At 32-33 weeks, I had a rupture uterus. I still can't forget that. We lost the baby and we could save the mother. So we should be very cautious and we should be helping our friend. If someone has done it and come to me, I should call up and tell them not to criticize, but to help, because we need to optimize our technique. We need to optimize our suturing. And that is what I think every endoscopic surgeon over the period they become. What are the complications that can happen subsequently on immediate 7 days post-operative or 3 months, 1 year, or when she is pregnant, and we start taking preventive steps now only. So preventive obstetric, preventive endoscopy, this is how we work, I think.
And one more thing, if the patient is very anemic, 6 to 7 gram hemoglobin like that, we get girls like that. So do you give any progesterone pre-operatively? How do you manage them?
I give a blood transfusion to them and I take them for a surgery. I don't give GnRH or anything to reduce. It takes months together to improve that hemoglobin and keep the patient pending. So I give a blood transfusion at 6 grams.
I have found this FCM injection very good. Like today, if you give
yes, FCM will take 10 days में 1 gram. It will still take 1 month. It will become 9 gram. By the time her menses come, she will come down to 7 gram. Again, you wait for 1 month. It will take you 10 gram. Again, she will bleed. It will come to 8 gram. So you keep on playing anyhow with 2-3 months. But if you give
I would like to differ. Like we
That's
give 1
beautiful.
gram FCM and I give a norethistone. Within 20 days, patient is ready from 9 grams to 12 grams. I think you try 1 gram thing and let the patient not have a period in between.
Yeah,
and you
Nilesh,
can
I'm
easily
joining.
operate
Give
in
me
20,
1 minute.
22 days.
My experience is also same with the IV peroxymaltose or whatever salt we are giving. And in between, we are given norethistone and patient is prepared by the next cycle.
Blood is very rare in our
But it's
Wonder-
not required.
A wonderful experience. I will try, but 6 gram hemoglobin, I myself is equally worried. And usually what happens, Dinesh, patient are not from Pune or somewhere. You get a global patient.
Correct.
So they come with their ticket, they come with the 10 days in hand, and then you land up in some different. But this was a fantastic carry-on message which you gave.
Thank
Madam?
you so much for answering the questions. Like, I tried to tell
Madam,
every
But
day.
we have now beautiful videos of Dinesh and Subash.
Madam, may I
Subhash has
just-
few questions.
Yeah,
Yeah.
Dr. Nilesh Balkaude is calling me for the other webinar. Can I join them? It was wonderful talking to you
Just-
all.
just
1
5
minute,
minutes, ma'am.
Sunita.
Yes,
One thing is that your carry home message is don't limit your challenges. That is very,
Yes.
very important message
Yes.
you have given. And chasing the excellent. The other second is this thing.
thank you.
One very important message, but we must give 1 minute to Dr. Subhash because he wants
Yes,
to
Subash.
add something. Subhash.
No, ma'am, nothing to add, ma'am. I just want, because since madam is dealing with infertility, I know Nilesh is calling for a POGS meeting. I just have a couple of questions. ma'am. Just I need to know your basic input on how would you put an incision in such cases, ma'am? Whether you will put a vertical incision or a horizontal incision in cases of fibroids in infertility. Would it differ from your normal case? First question.
No. See, if it is an anterior wall, I will go with the vertical incision. If it is posterior wall, I go with the horizontal incision. If it is a fundus, I go with the vertical incision so that I don't damage the cornea. But what is most important is sometimes the fibroid may be oblong. So my incision also may be oblong towards the direction of the, so it doesn't. I'm an ipsilateral surgeon, but ipsilateral usually loves horizontal. But let me tell you, anterior wall vertical incision becomes much simpler to take. Initially, I used to do maybe a decade ago, horizontal incision, anterior, posterior. Over the period, I changed to anterior to vertical, and I'm finding it very easy.
Yeah, in addition to that, at the end of the surgery, would you like to see the tubo-ovarian the anatomy?
That is why the fundal incision should be vertical, so that your incision, which is extending, at the time of an incision, you may not feel, you feel you are 4 centimeters anteriorly or posteriorly. But when you take out the myoma, you realize you are very near to the cornea. So don't take for a fundus horizontal incision, always vertical incision.
Second question is.
Now Dr. Parag Biniwale will kill me.
I will.
Let him kill you. I'll tackle him. Don't worry.
I have one more. Since your topic is fibroids and infertility, ma'am, I would like to know about your hemostasis, ma'am. How would you would like to go for aqua dissection or will you go for a cautery, electrocautery? What is your case?
No. If you are in right plane, Subash, the bleeders you don't get in. So my first most important thing is when I take an incision, I little bit overcut on the capsule or the myoma 2-3 millimeter inside. So automatically the capsule gets opened up and you see the naked myoma and you remain in that naked myoma plane. So larger, more and more. And then you put the aqua fluid. Yeah.
This is a very important point for all the audience who are still with us.
Maninder, thank you so much. Thank you, Dinesh ji. And Dinesh, I loved your Gale Ka Mala. Whatever is that, I'm going to see that later. Subash, don't feel shy. You can also gift out to your wife. Thank you so much. And Jagsonpal, Deepika, lovely to meet you all. And I'm sure our discussion doesn't end. I'm going on Facebook to see Dinesh, your videos later. Thank you, Subash. And thank you, Dinesh. You are my dear friends. And Maninder, thank you so much. Maninder, you are going for a FOGSI election. I'll take you and see how I can do. I'm so thankful to you, Maninder, for that. You are lovely, darling, and a friend of years. Thank you. Thank you.
Thank you for joining, ma'am.
Thank you.
And these were I think I didn't realize it will be so good presentation by you and so exhaustive. You have covered everything. There were hardly any discussion left. But I'll still expect now Dinesh and Subash to carry on for the discussion at least for another 10-15 minutes, whatever they can. Thank you. Dr. Dinesh, you
Yeah.
and you can carry on if you have some videos to show.
Yes,
Can we
so
see?
Maninder, it was more like a rapid fire. We try to discuss it so fast and so many
Yeah.
things.
It was, actually, it was a rapid fire presentation also. It was a
Right.
continuous.
That's right.
But anyway, if you want to discuss anything, we still have time with us, so we can discuss.
Right. And Dr. Subhash was asking about the incision. What is my preference is anteriorly, I take slightly oblique, obliquely going downwards towards the right, because being ipsilateral surgeon, this is how my
Exactly.
needle holder is going. And posteriorly, I'll take slightly oblique going down on the right, so that again my needle holder runs like this.
Now, when you put in ipsilateral suture, would you start from proximal to distal, or you come from distal to proximal?
See, if I have a good assistant, I can start from distal end because she will show me the direction. And if I do not have a good assistant, then I know I have to follow the thread and I have to hold the myometrium. I'll go from my side from proximal to distal.
Okay. Now, continuing to the questions which I wanted to ask to Sunita ma'am, I would like you to ask, ma'am, is regarding the hemostasis, ma'am. Since we are dealing with regarding the hemostasis, ma'am.
Yeah.
Since we are dealing with fibroids and infertility, ma'am.
I think I'll show my.
Yes, ma'am.
I'll share my screen and let's have some videos.
Yes, ma'am.
So we were talking about the hemostasis. So, one thing I'll show a vasopressin video. That vasopressin is not without risk. Can you see my screen now?
You can screen, but you make it full screen.
Okay.
Then video will be running.
Yeah. So
Video
you
is
can
not
see-
running.
Is it okay now?
Yeah, now you run the video.
Yeah. So here we are injecting vasopressin and you see what happens. So this is, you can see blanching, but
Yes,
something is
blanching.
going in this vessel. So our peripheral vision is very important. And so we have to, you can see it going in the vessel also. So once you are in the right vein, it would stop. So our, lateral vision has to be very good. So I'll just, so that is one. So this is our most standard thing. And talking about how much vasopressin, as Dr. Sunita said, in a very large fibroid, even vasopressin is not going to work. Normally, we like to inject it one place and it spreads all over. And the usual concentration we use is 10% and not using more than 5 units. If it's a very large fibroid, then we try to dilute it further, like into 100 ml or 200 ml. And I would like to show the, about the hemostasis. We have, you can ligate the uterine artery in a reversible manner also, because everybody has a concern about the blood supply. So this is the video where we will be ligating the left side, right side, and then opening and starting of the circulation again. So this is the left side retroperitoneum, starting from the round ligament, going along the infundibulopelvic ligament. And here we, this is the harmonic doing a wonderful job. So just cross the pelvic brim so as to be able to see all the structures. My videos are fine, Dr. Maninder?
Yes, we can see it.
Thank you so much. Go a little deeper. And so as we go fiber by fiber, so that, there is no bleeding in this area, because bleeding will spoil your field. Now we started seeing the external iliac vessels. So we go a little beyond because we want to see the ureter also. So here now, here would be internal iliac. This is external iliac vein, and here will be the uterine artery as well. But it's very essential to see all the structures so that in case there is a bleeding, we are very safe with the ureter too. So here we should be finding the ureter where it is crossing the bifurcation of the common iliac. So here soon we will be seeing the ureter. So external iliac artery vein, and the assistant has to be proper counter traction. So here we can see something, and there's peristalsis, that's the ureter. So we keep in between the ureter and the external iliac vein. And here we are seeing one structure, then we have to see whether it is obliterated internal iliac or it is the uterine artery. So uterine artery will cross this space, whereas internal iliac will go anteriorly. So this is the uterine artery. You can see all the structures very well. Psoas muscle, external iliac artery, vein, the ureter, which we just saw the here, and this is the uterine artery. So I'm holding the internal iliac. I almost skeletonized. You can see it, you know, the pull when you pull it, and then you separate the uterine artery from the vein and from the surrounding. You can see the vein behind. Now you can either take the suture on a Maryland, or you can take it on a needle also. So here I'm taking it on the needle, simple vicryl suture, and I'll be tying a shoelace knot. Shoelace knot is same as you tie for your shoelaces. So look at it, how I take the knot. And now I'll be leaving one end little longer so that I know which one needs to be pulled later on to take off the knot. So it's a single knot in shoelace, similarly on the right side. Similarly on the right side, we've taken the uterine artery and tied the shoelace knot. Then we complete our surgery, especially if it's multiple myomectomies. Then you can leave the knot on, because it prevents the recurrence of the fibroids to some extent. But if it's not many fibroids, then we would like to take off the knot later on. So that's on the right side. No, 1 second. So now we pull out the knot. We've completed the surgery, and you will see the pulsation starting in the uterine artery. So here we go. Similarly on the right side, you can see the vein behind, that's the artery, and pulling on the knot. And we'll have a close-up here. You can see the pulsation starting, especially for a, you know, even if there's small thrombus, it will get recanalized. So this is a good method of hemostasis. So this is about the hemostasis that Dr. Subash Mallya was asking. So we have both the vasopressin still remains the standard method of hemostasis, most convenient and simpler. But of course, we should not exceed the volume or the amount which should be there. And so I'll show another video. This is sometimes we come across adenomyosis. And adenomyosis surgery is not the standard surgery to be done in an infertility patient, but as Dr. Sunita said, if it's large and impinging on the cavity, then we may have to do. This is on my YouTube also. So that's the, you can see the MRI, the typical adenomyosis, and it's a large one. You can see the bulge on hysteroscopy as well. Because it was very large, we will be doing the uterine artery ligation, but I think I'll skip this. We've already shown. So there are various incisions which can be planned. You can take a straight incision and try to make flaps and remove it. But in case of large adenomyosis, usually it's not able, we are not able to remove large amount. And here I'll be taking a cruciate incision. You can see the incision I'm taking, as I was saying, little oblique, this one. And you can go towards the round ligament, but not the tube, or below the round ligament. This is the safe direction you have. So now I've gone deep enough, but leaving the cavity. In the initial MRI, you can judge what is the maximum thickness of adenomyosis, where exactly it is situated. So accordingly, I'll make a deep cut so as to remove maximum amount of adenomyosis. So here I made a T-shaped incision, and now we have to leave about 0.7 centimeters with the flap, even though it is not a very healthy flap, because we need to cover the wound. So here we are going deeper and removing the adenomyosis. You can see the chocolate colored fluid which is coming out, which is typical of adenomyosis. And the aim is always to remove about 60% of the adenomyosis, because we can never remove complete adenomyosis, because most of it will be with the endometrial cavity. And of course, we do not want to remove the any part of the endometrium and avoid damaging it. So we can see now this is the second piece which is coming out, and it's like it can be kept in posterior pouch and removed later on. And now that's the third piece. And once you remove these, you can remove the pieces in stages so that the inner part bulges out and we are able to remove more and more rather than trying to remove everything in one go and more chances of damaging the endometrium. So you can again see the fluid coming out, which is so very typical of adenomyosis. And this healthier tissue shows this is the healthy myometrium. So here we've removed most of the adenomyotic tissue and you can feel with your instruments the haptic touch that you have a softer tissue which is remaining. And I am very fond of using tenaculum for counter traction as you saw. And then the barbed suture does the job for the suturing. So that's, we'll just run it and we can see the end stage of it. And then you can remove the pieces by cutting or through, if they are larger, you can even morcellate them. So this is one thing, and what I wanted to show was Dr. Sunita did not show any in the in-bag morcellation. So we will be showing this here. It's this one, yeah. Yeah. So this is the in-bag morcellation which I'll be showing, especially for the patients who are above 40 or you have a degenerated fibroid or wherever single fibroid where you can suspect a leiomyosarcoma or LDH is borderline with lot of these legal implications. I think it's safer to use a bag rather than going morcellating without it. So here is a large fibroid which is coming out, anterior fibroid. Suturing being done, multi-layer. And then we proceed with the morcellation. So the bag can be, this is the bag, you can fold it. It's a stomach shaped bag. This is the morcelled bag. So you can roll it and put it inside or you can put it directly. So take it out from the inserter and put it in the abdomen as it should be later on. So we are unrolling it. The mouth is wide. You can see this degenerated fibroid. We are putting it inside the bag, mouth of the bag. And this mouth is taken out from the left lower port where we will be inserting the morcellator as well. So this is the morcellator, that's the outside view. Now the tail is brought out from the laparoscopic port and a pseudo peritoneum is created. And whatever pieces are there, they are left in the bag itself. So even if there's a recurrence of myosarcoma, it would be local. It will not be spread all over the abdomen. So that is the best part. And hence doing in-bag morcellation is a good idea. So next would be, yeah. So cervical fibroid. We should not worry about cervical fibroid much because it looks scary, lot of blood vessels, because the uterines come above the fibroid when it is a typical cervical fibroid. And we have to see the thinnest area and where we can do the best surgery if it is a globular one. So this is older video, so using a monopolar hook. Now I like to use harmonic only. And usually the myometrium over here is very thin because it is a cervical fibroid and usually bloodless surgery. And you don't always have to dissect the ureter unless it is very lateral, or because if you keep intracapsular, you are always safe. So it is not that always ureters and uterines have to be done. And keeping in intracapsular dissection is the best thing to do. And that's a robotic surgery, as Dr. Maninder said. I am a robotic surgeon as well, though basically I'm a lab surgeon. This is our XI robot. We have two in the hospital because one is used by onco people completely. So these are the robotic arms. And we put in the port, same as for laparoscopy. First is the blind port, and all are 8 mm ports, and none of them is 10. So these are lateral ports. And now attaching the ports to the robotic arm is called docking. Sterile drapes are already there. And then I sit at the surgeon's console comfortably. And we have a beautiful 3D HD vision, as you can see. And these are my hand controls. So this is fenestrated grasp in my left hand. You can see over here, The second arm has the telescope. The third arm has the spot shears, that is scissors. And the fourth arm has needle holder. Now, beauty of the robotic is you can suture in any direction comfortably because of the 360-degree rotation of the wrist movement of the tip of the instrument. So the movement is here rather than at the skin level. So the pain also is much less post-operatively because there is no levering at the skin level. And here, there's a small disadvantage. I can't feel the tissue, whether it is soft or hard. There's no haptic sensation, but the view is so good, the vision is so good, and camera control is steady. Everything is in my hand. I can take the camera in and out. That even small blood vessels are seen beautifully. As a result, the bleeding is much less compared to routine laparoscopy also. And you can see the things are not moving because you have, slight movements in your hands normally. And this is downscaled in robotic surgery. And also the same thing with the assistant. They keep on moving camera slightly, but here the camera is so very steady. So these are my hand movements, which are downscaled inside. And hence no tremors. This is camera control. This is, to change the gears. And the right side are the energy controls. This is for left arm. This is for the right arm. So at a time, you'll be moving one. So there is laser guide. So you know which one you are touching. And whenever you activate the energy, there will be a marking over here. There will be a marking at the arm level. So you can see it is green and blue. So this is, whether you're using bipolar or you're using monopolar energy. And then suturing comes so handy. Suturing is definitely a little better with robotic, but of course an experienced laparoscopic person can do suturing equally well. But I think for a beginner who thinks laparoscopic surgery is impossible to do, but she really wants to do, I think, and if the hospital has robot, this is one way you can satisfy yourself by doing endoscopic surgery. So all laparoscopic surgeries are called robotic assisted surgeries because all the principles of laparoscopic surgeries remain, but the only thing is morcellation has to be done laparoscopically. So you can see how comfortably I am moving the needle and taking baseball sutures, which you finally cumbersome on laparoscopy, and you enjoy suturing rather than finding it a burden. And I think Dr. Sunita covered most of the hysteroscopic principles. There's one interesting video. This is the hysteroscopic morcellator, though it comes in handy for small polyps, small fibroids, not for the large ones, but it keeps your field so clear and it just sort of eats up and sucks the pieces inside. But because it gives just small pieces and the blade also becomes bad very soon, so it's not come very popular. And you can see how clean the base is, no energy used, just the physical energy, and whole of the endometrium cavity is normal. Suppose there is some shred, this also can be taken by the morcellator. So I think that completes myomectomy from Dr. Sunita and my side, and we will wait for Dr. Subash Mallya to add his pearls of wisdom further. I thank Dr. Maninder for this beautiful, beautiful webinar. And you are pride of North, and not only North, you are a huge national figure and the international person. And I heard you when we were sitting in the flight for Indore, and I was mesmerized by your passion for your work, the way you were speaking and your leadership qualities. And thank you, ma'am, for making me part of this and being associated with you.
Thank you, Dr. Dinesh. Kansal, you have done the excellent work of being a Manthan specialist or brainstorming. So I think the two of you together, Subash and you, have done the wonderful job, and you have added icing to the cake, and a beautiful cake presented by Dr. Sunita. She's not here now because I must love to share here my new project. I think I'll expect Deepika to help me in that also. That is the cross-sectional study in the South Asian countries on the relationship of menopause to metabolic syndrome. because this is the topic which needs research and our own data collection, because the incidence of metabolic syndrome increases from pre-menopause from 16% to 60% in the menopause. And there are asymptomatic heart attacks when they start HRT. So all these asymptomatic patients, they have to look into, and it is being done for the first time on the Google survey forms, and it has the ethics approval. And we expect all the healthcare workers, women between the ages of 35 and 60 years, to fill up these Google forms. But just 1 week back, and the feeling which I get is, we healthcare workers are not bothered about our preventive health at all. I tell you, I feel astonished when the lady doctors, they have not got their done lipid profile and blood sugar even once, and they are not willing to get it done. So perhaps I'll need the help of pharma companies now to approach to them and to get it done for them, because it's very important when the WHO says that we should be doing these studies in the hospital setting, in the medical professionals' own setting, so that the health awareness can be created. I think, Subash, you should get it done on your wife first of all. Please unmute yourself. Subhash, yes.
Yes, ma'am. No, I just got a call.
Okay, that's why
No,
you
no. Ma'am, as Dinesh, I actually wanted to ask a few questions to Dinesh madam also, ma'am. Like regarding this particular, since you showed me the shoelace knot, I actually wanted to bring in that particular point now, the shoelace knot. Since, in fibroids with infertility, doing a lot of coagulation is also not good. Again, you're doing for uterine artery ligation at origin, because we do not know about the, the future fertility aspects also. So this is where actually the shoelace knot which madam had shown, it is really, really useful. Of course, 9 out of 10 cases will be very happy with the vasopressin. Use of vasopressin will be good enough. But in certain cases, where we need to know something beyond the vasopressin, we'll have to go. And that's where I really appreciate madam's technique of, the what do we call that?
Shoelace stitch.
Yes. Actually, I wanted to bring that particular discussion on that, but since madam showed it, it's very nice. And regarding the other question, ma'am, whenever we do this any surgery for infertility, I think let's not forget that any finding is a positive finding. So if you see a very small fibrosis cyst, not related to the topic first, in the tubes, you see a small fibrosis cyst, always go and remove this fibrosis cyst also. Because I think they will also cause a lot of, infertility aspects also. So look for that.
Right. The follicular person will have, going it easy, and also the IVF person once he removes the cyst.
No, if we go by any randomized study, we don't have any randomized study to say that removal of fibrosis. But I think when an infertility patient, as we always say, any finding is a positive finding. So go for that. Again, once we finish the myomectomy surgery, however well we have sutured, at the end of the surgery, I would always request everybody to go and see the tubo-ovarian and the anatomy. Because sometimes what happens, because the suture, it may get kinked. Of course, it may be temporary, it may be delayed, but then still some amount of kinking actually will cause a lot of problems in your future fertility aspects. So please do make sure that the tubo-ovarian anatomy is actually well maintained. That's one thing which I wanted to suggest. Again, ma'am, robotic, kya kaya, ma'am? I have no words. Very nice as usual. Excellent.
One more thing, Dr. Subash, I would like to, interact with you. Suppose the patient has 2-3 submucous fibroids, and she's got large 3 fibroids which are to be done laparoscopically. So how do you deal with them?
Madam, I always, whenever I see any submucous fibroid more than 3 centimeters, and sometimes occupying almost half of that, actually, I don't go for any submucous resection. I actually go over laparoscopically. It may be very controversial, but then what I'm doing is, in case of infertility, I do not want to damage the endometrium. At the end of the day, I do a very good submucous resection. Along with it, I would have damaged almost 60 to 70% of the endometrium. I'm not doing any justice to that lady. So it could be controversial. People may not like what you said, but then that's the end of the day. The patient is of utmost importance.
That was the opinion of Dr. Sunita also, that we should go laparoscopically and we should not go hysteroscopically.
If it is a very
intramural and submucous both are there.
Madam, I wanted to know, suppose the patient has 1 centimeter, 2 centimeter submucous fibroids, which need to be removed hysteroscopically only, and at the same time she needs laparoscopic myomectomies also. Like she's got large fibroids.
The point which you say,
Intramural.
ma'am, 1 to 2 centimeters submucous fibroid, definitely yes, ma'am. We'll go hysteroscopic resection only. I'm only talking of larger size fibroids,
Yeah,
ma'am. Where
right.
definitely no. Less
Yeah.
than 3 centimeters, and if it is Dinesh madam or somebody who is doing 4 centimeters, I can accept it. But otherwise, for those who are not routinely doing submucous resection, let us not go ahead and do any of these heroics.
Yeah, and if you have both the things in one patient, then I would like to inject vasopressin first, go hysteroscopically, and later on do the laparoscopic job so that everything turns out to be bloodless.
1 to 2 centimeters, definitely yes. I agree with your point of view, ma'am. That definitely yes. Hysteroscopic is better, but it's more than 3 centimeters only. Then I'm not very adamant about ma'am, the 3 centimeters. So only thing is, if you're really good enough, go ahead. You're fast, go ahead, no problem. Otherwise, let's wait for some more time.
Achha, have you used for hysteroscopic myomectomies? Have you used vasopressin? Because I've tried it, it's working very
Yes,
well,
ma'am.
and it's recommended by AGL also. So can you tell the audience where and how to inject it?
Ma'am, I actually inject it on, I make it a very dilute vasopressin. I said 20 units in 200 ml and a normal saline. Sometimes I play a little bit of stingy enough, where I take 5 units, I keep it in the fridge for the next case also. But of course, when you're doing it, you inject it at the level of the cervix, just like we're doing a paracervical work. But in this case, be very careful that you aspirate it very well, because you have a lot of vessels which are coming on the cervical vessels. You do not want to inject it and cause bradycardia. So it's very, very important to initial bradycardia followed by tachycardia is what we normally see, but then bradycardia, if it goes severe, it's very, very difficult to tackle. That's a very, very careful. Aspirate every time. Whenever you're injecting in one place, taking out one side. Of course, the other aspect again is if you can use a hysteroscope, you can use a very small, like what do we call that, ma'am? The needle, ma'am. The normal needle also can go inside. I've seen Dr. Nitin Shah use it, very often. But of course, there's a lot of trick to use it. It's when I don't personally use it. It's very difficult to use it. Go inside and inject it on the vasopressin and come back. You have any other technique, ma'am? Dinesh, ma'am?
Yeah, because we don't have to go paracervically. That's what I feel, because even in laparoscopy, we go at the point where the myometrium and the fibroid joins. So what I do is, you can go, suppose it is an anterior fibroid, you can go anteriorly just in front of the cervix, and you can feel your needle going into the myometrium. So same as laparoscopic effect, this will also have the effect. You push the vasopressin. If it's posterior, go little posteriorly. So wherever your myoma is situated, so you can go nicely into the planes in between. Your myoma will shell out easily and bloodlessly.
We have got lots of pearls of wisdom today. And this webinar has been a successful, actually, pearls of wisdom by the key opinion leaders. I think there are no more questions there. But lots of appreciation is there by the delegates that it has been a wonderful webinar. Dr. Subash, do we have anything more to discuss? Dr. Dinesh?
No, I think
my pleasure to share the stage with Dr. Subash Mallya, who is such a prominent personality.
No, ma'am. It's always been. I've watched you. I've learned a lot from you.
Young torchbearer. I'm selecting people whom I know they are going to lead our organizations in the future. So that's why we are looking at him. And I think he will go on doing and proving himself by his good work. So that is how we will have to rise by.
Thank you. All your blessings, all your elders' blessing, ma'am.
I don't believe that the post gives you an opportunity to work, because if you are passionate about working, you can work from anywhere. So I started new Society of Meaningful Life Management with the same purpose. Who want to work can work from this platform, because it's a large, huge country. And so much of work is needed to be done. Sometimes I really get, I don't know, I get disheartened how to do this lots of work before I leave. So many miles to go before I sleep. Many miles to go before I sleep.
Thank you, Dr. Maninder.
Thank you, ma'am. Thank you very much, Dinesh, ma'am, for this wonderful opportunity. Again, thank you, Maninder, ma'am, for this wonderful. Again, I would like to thank Jagsonpal, the whole team of Jagsonpal, and I would like everybody to remember the names Fibristone and also EndoReg, ma'am. Thank you very much.
Thank you. Thank you so much, sir.
And I think there's a lot of role of medical management. If when you have multiple fibroids and the girl is not planning pregnancy immediately. Suppose she's an unmarried girl and she has to wait for years before she conceives. I cannot tell her ki shadi kar lo, bacche kar lo. So in between, the Fibristone will cover her very well. Now Yuliprist is not there. So I think Fibristone is the answer for long term.
Ma'am, Yuliprist is now back. Yuliprist is back. Yes, ma'am.
Deepika, I have used Yuliprist in so many patients, especially in the perimenopausal patients, and they have normal periods till the time they go into menopause. So
Ma'am,
many
you see,
patients I have gone through where they
Thank
didn't
you.
need hysterectomy because we just don't advise hysterectomy if we can control the bleeding. Their problem is bleeding, not the fibroids, because the medium-sized fibroid, they are not going to cause you any pressure symptoms also. So if the bleeding is controlled and they become menopausal, our problem is solved. There is rarely any cases of malignancies reported in the menopause itself in the fibroids.
ma'am, in Yuliprist, there was a issue that the LFTs need to be now monitored every 15 days during the treatment, at baseline and during the treatment. 15 days. LFT monitoring is to be done, but now it is back and you can prescribe it, ma'am. Especially in those patients who are not the right people for surgery. It is for those. So in fact, today my teammate is here with us, our salesperson from New Delhi, Mr. Rajkumar. So he would like to just request a little for his products. These are our 2-3 products.
Good evening to all respected doctor. I am Rajkumar, Area Sales Manager based at South Delhi from Naari Division, Jagsonpal Pharma Ltd. Thank you for this opportunity to connect with you all today. Doctors, Naari Division proudly present Fibristone 25 tablet containing Mifepristone 25 mg, safe alternative to surgical management of uterine fibroid to tones down fibroid with symptomatic relief to the patient. Doctor, also Yuliprist 5 mg tablet of Ulipristal acetate for long-term use management of uterine fibroid. Please consider mandatory monitoring of LFT level before and during treatment. Our other excellent product are EndoReg 2 mg tablet of Dinogest for management of suspected and confirmed cases of endometriosis and endometriosis pelvic pain, and ProRetro 10 mg tablet of fully indigenously developed micronized digogestin assisting motherhood, delivering happiness, offering economical therapy to patient at ₹50 per tablet. ProRetro is readily available at all the counters near you to prescribe. Doctor, looking forward to your support to our brands Fibristone 25, Yuliprist, EndoReg, and ProRetro. Doctor, do join us for the next episode of this web series on 10th of May, Pulse of Wisdom by KOLs. Topic will be metabolic syndrome, hosted by Jagsonpal. For the attendees today, same registration link will work to join the webinar. Thank you.
Thank you, Mr. Rajkumar, and thank you so much, all the experts, for
Thank you.
putting in so much of your
Jagsonpal.
time.
Very much.
Thank you.